Thank you all for being here and for being online, for everyone who's at home on a Saturday morning, and I'm really very excited to be here. And I'm a little disappointed that you had the homework of seeing my slides beforehand, because I was hoping to surprise you with my slides, which I was kind of happy with. I have to say I'm very happy to be talking about constipation. Because it affects so many people and dogs, and it can be so serious, but we can also have tons of fun with it. And I want to tell you a little story. So when I first came to Hawaii and I was a fellow in geriatric medicine, and Kamal Misaki was my program director. That's why I'm so youthful. Anyway, which was a very long time ago, we rotated through different hospitals, and very first day of my very first rotation, and I'm sent to a hospital, and I get a new consult, meaning I have to go see I have to tell you, I'm interrupting my own self. First of all, I do that a lot. You may need to, rein me in. It's very hard for me to stand in one place, but I'm going to try. I really kind of want to. But I get sent to a hospital, and our job is to see older patients who are not doing well at all, right? Not only are they sick in the hospital, but the regular doctors are still even having trouble. They have another question, another problem, another issue that they want input on. And the thing that they wanted input on is, does this patient in the hospital have the capacity to make decisions? What does this have to do with constipation? Is this just her ADHD and she's just all over the place? But probably. But anyway, so we learn in geriatric medicine how to do these type of assessments. So I go to interview the patient to see if the patient understands the situation. And the problem is that this patient has stopped eating. He does not want to eat. When they try to feed him by mouth, he pushes away, and if he doesn't start eating soon, he's going to die. They've tried IV fluids, but they really need nutrition, so they tried, because he's refusing, to put a nasogastric tube, nose, gastric, stomach, tube that goes from into the nose, down to the stomach, in, so that they can give this patient artificial nutrition, because the daughter is insisting, you have to do this. You have to artificially feed my dad. He needs this to survive. But now the son is saying, he keeps pulling it out. He doesn't want it. He's saying no. He's just ripping it out. They are terribly uncomfortable, these tubes. And so my job was to find out if this patient really understood the risks and benefits, the pros and cons of being artificially fed by tube. So I go in there and I try to talk to the patient, but this patient is so confused and so just not able to come, like what I say, to the surface, come to me and engage with me in any meaningful way. And I'm like, okay, let's figure this out. And so I go to do my full physical exam, because I can't get a history from the person. And I, listen to the heart and listen to the lungs and and because I'm a geriatrician, we roll everybody over and we stick our finger up their butt. It's where the money's at, right? So I roll him over, and 5 cents worth of lube, stick my finger into his butt, and boom, 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 boom. There is just a wall of rock hard poop in there. Early for this story? Is this too early? Sorry. With some lube, and then I asked the nurses to do a tap water enema, and I figured, I don't know clearly the patient can't make this decision, so I'm going to call a family meeting for a few days and talk about the issues and whatever. And I come back the next day after cleaning out my patient and walk in the room, and not only is he awake and alert, but he's eating. And that question is moot, and my work is done. And for 5 cents, I am a hero. Woohoo! And I just wanted to tell that story because that's why I love to talk about constipation, because I get to talk about how wonderful I am. And, and really why I want to tell that story is because I want everyone to understand how important this issue is and the connection between the mind and the gut. And I've always since then said, and my brother, who's a neurobiologist, he studies the brain. I talk a lot about the gut. He even says, we call this the little brain, and we call this the big brain. So today we're going to talk about the big brain. And I think we all knew that was the big brain, right? Because we all use expressions that basically illustrate the fact that this is the big brain. When you kind of know something immediately, what are you having? A gut reaction, right? Your gut is telling you something. It's your big brain. Okay, anyway, so here goes. Okay, I want to put this down. Okay, so we'll talk about today, like, what really is constipation, who gets affected, if anybody has bathroom jokes, why should we care about this, when do we worry, and how do we get help for this? Where do we get help? So, and maybe even talk about what does the poop emoji really mean. Has anybody ever used it? Okay, I'm not sure. I think Virginia's used it. I think it's one of these beautiful emojis that can mean so many things. Could mean like, this is hitting the fan, or I don't know what's going on. Okay, so constipation, one of the most common digestive complaints in the USA. I'm going to say beyond that, even just one of the most common physical complaints. 15% of the population at any one time is affected, and as we get older, the incidence increases. And the more frail we become, the more we're affected by it. So maybe only 18 to 20% of older people who live in the community, but if you end up in a nursing home, 74% are on laxatives. And women more so than men, probably for a variety of factors. Okay, so there actually are specific criteria. Isn't he the cutest? There are specific criteria for constipation. The Rome 4 criteria can look at how many bowel movements you have per week, if it's less than or equal to 3, if you need to strain more than 25% of the time, if you're more than 25% of the time your stools are hard, dry, or lumpy, if you feel that you haven't completely evacuated, or you feel there's a blockage, if you need to manually disimpact. And if I use any words that you don't know, manually disimpact means using your hands to actually have to pull the poop out, which is something that I do for very sick people, often at work. And my dad was like, oh my God, I'm so proud that you're going to be a doctor. It's so glamorous. I'm like, Dad, if you could see me now. But it's very satisfying, you know? Like, I'm not a surgeon. There's not a lot that I can do that causes, like, instant success. So, I love doing this. That was probably too much information about me. And then we don't, for just regular constipation, we don't want this to meet the criteria for irritable bowel syndrome. So irritable bowel we can talk about. There is a form of irritable bowel. Irritable bowel does have some constipation, and that's one of the main kinds of constipation we'll talk about. That's not the same as inflammatory bowel disease. Even in my mind, a lot of times I'm like, ooh, IBS, IBD. You'll see a lot of commercials these days for medications for IBD. That's inflammatory, meaning like inflammation, bowel disease. That would be Crohn's and ulcerative colitis, which can be life-threatening, systemic diseases. Systemic meaning your whole system. Today we're going to talk about IBS, which is irritable bowel syndrome, which is an annoying but not dangerous condition. So we'll also talk acute versus chronic. So acute constipation is something that you get maybe temporarily, maybe you were traveling. Everybody gets it sometime in their life. Any woman who's ever been pregnant had it. Anybody who ever, took over-the-counter cold medicines for something has it. It's chronic if it persists for 6 months or more. So to meet the definition of chronic, you actually have to have it for quite a long time. Some people think that the definition is if you have to sit on the toilet for a really long time. I don't want anybody sitting on the toilet for this long, okay? So we don't use that as a criteria. What we do use is this handy-dandy little chart, which actually looks like cartoons, but we literally use this in medicine, and it's called the Bristol Stool Form Scale. And it just helps everybody communicate about what is constipation, or what, to talk to your doctor about your poop. And when we get very formal, we basically say, well, I've got a type 3 or a type 2. But, really, your doctor's just as happy if you say it looked like a sausage or it looks like corn on the cob, and then they kind of know what they're dealing with. My partner, Dr. Ando, yesterday said to me, but what if you actually eat corn? Does that count for a corn on the cob poop? And I thought, God, I hope nobody asks that question tomorrow. I think we just call that a corn poo, and we like to have it because then you can tell how long your transit time is from mouth to bottom. It's like you go, okay, 36 hours, good to know. Everybody's had a corn poop, right? Some things, yeah, right. Okay. Today, we're not going to talk about the dangerous forms of constipation, the ones we super worry about. But here are what we call the red flags. And if anybody has any of these red flags, we really want this brought to the attention of your doctor. So, brand new constipation when you get older, right? Because what are we worried about? Older, cancer risk increases, brand new change as we get older. Also, there might be other reasons, but that's why it's a red flag. A new change in the stool character or color without any other lifestyle changes, that's also a red flag. Rectal bleeding. Abdominal pain or an abdominal mass. All these things are telling us something serious otherwise is going on. Inability to even pass gas. Right? That's more than constipation. That's what we call obstipation, means nothing is coming out. That's an emergency situation. Vomiting, fever, weight loss, or a family history of colon cancer or inflammatory bowel disease. Remember, that's not the irritable, irritation, you're annoyed. Inflammatory, inflammation, a serious medical condition. Are you all with me? Okay. Okay, some people say, well, what about the color of my stool? Does that indicate something serious or a red flag? And it may or it may not. Stool, your poop, and I'm going to use the different medical terminologies for poo, including doo-doo, caca, poo-poo. Anybody has any others, BMs. You know how important a concept or a thing is when there's many words for it in a language, right? We always say, snow is important to Eskimos. They have 21 different words for snow. So as Americans, we have many, many words for poop. So anything in the brown range is usually a normal poop, but it will change depending on all sorts of different things. What you ate mostly, even how well hydrated you are. And then people say, well, what if my poop is black or red or dark purple? Actually, that is in this, how do I point? Okay, here. Poop that might be okay but might not is over here. And things that we really worry about being unhealthy, gray or this sort of citron kind of color. But even these colors over here might be okay, because red, some people say, oh my God, my poop turned bright red. It's like, what were you eating, right? Beets, thank you, right? That scared the poop out of me one time. I'm like, what is going on? It's like, oh yeah, I ate beets. And I otherwise felt well, and the timing was exactly right. One time a friend called me up, my poop is black. And I'm like, what did you take yesterday? Pepto-Bismol. Okay, that's, you ate, Pepto-Bismol, or you started an iron supplement, or I think you'd have to eat a lot of licorice. I don't think that that's going to happen anywhere here. And then, once again, any shade of brown, you're good. A little green is okay. A lot of green, it may be you're passing stool really quickly, so something's going on acutely in your GI tract, because that might be sort of tinged with a lot of bile, or you ate a lot of greens. The ones that we worry about, again, pale white or clay colored, might be a gallbladder or a liver issue. And red, if you're also feeling sick or you have a history, this could be a lower, but GI bleeding in your gastrointestinal system. So when I say GI today, that means gastrointestinal, gastro-stomach, intestinal, intestines. So lower bleeding from the bottom part of your intestines could be red. Bleeding from the upper part, stomach and duodenum and esophagus, because the blood gets digested, it actually may turn your stools black. But most of the time, you'll look back and you'll go, oh yeah, I took Pepto-Bismol yesterday, where I started iron, right? That's what we're hoping. So this just to illustrate that most, you can get some information from the color of your stool. But in terms of constipation, without red flags, without just your regular everyday constipation, the actual goal is just to be comfortable. So if the patient is comfortable, that's the goal. There's no evidence that I could find that people who poop every day are healthier. I know, right? If you're not pooping every day and it's not your normal pattern and you're constipated, you could feel pretty uncomfortable. Passing stools may be uncomfortable, you may feel bloated, and just like, you may lose your appetite, and if it gets severe, you can have more serious complications. This is an easy slide. How do we work up constipation? Any lecture that you go to for any subject for the rest of your life, the top, when it says the workup or making the diagnosis, the top thing is going to be history, history, history. Getting the story. The story is 95% of making the diagnosis. So when we say history in medicine, I'm not talking like Revolutionary War history or something. I'm talking about I sit down, I listen to the patient. And we have this weird saying in medicine, if you listen to the patient, they'll tell you what's wrong, right? Kamal's nodding her head. Yeah, we're not really good at that because we're always in a rush and we're always crazy. Sometimes you'll be like, the doctor didn't even examine me. You know why? 95% of the diagnosis is what you just told them. So, and the more deliberately you can describe things to a doctor, the easier it is. And they should also be asking questions. And then we add on top of that physical exam and a rectal exam. And why do we do a rectal exam? Because that's where the money's at, right? Willie Sutton was a famous bank robber, and he kept going to jail, and then he'd come out and go to jail and come out, and they'd be like, Willie, why do you keep robbing banks? And he said, because that's where the money's at, right? Part of the history, but I put it separately, is a medication review, right? Because also that's where the money's at. For the most part, as we get older, we tend to accumulate more and more drugs, and one of those babies is the cause. Specialty tests, really not a big part of this. Unless it's something that's going on and not being able to be cleared up, there's not really a lot of lab tests or x-rays or endoscopies that are really necessary for this diagnosis, unless we have what? Red flags, right? So the causes of constipation is generally the big one, like slow transit through the gut, right? Sometimes we think insufficient water consumption. I got to tell you, we're always like, drink more water. Not a lot of proof about this. But there's, we still think that there's probably something to it. It would also be really hard to prove that right now because you can't really take an entire population and say you guys can't drink water, see what happens to them. A change in a diet and the Western diet, like a lot of processed foods, are a big cause of constipation. Decrease in activity. Here's another one of my take-home, like if you're only going to take home like one thing I say today, and I think it fits in well with the fact that there's like going to be Zumba later. If you can do one thing that is best for everything in your life, physical activity. Move it, move it, move it, move it. Like I always say to it's like in the hospital I see so much constipation because everybody's laying around in bed. And I'm like, your gut is smart. It's the big brain. And if it looks at you and you're not moving, it's going to say, you're not moving. Why am I supposed to move? So activity, activity, activity. Some things, like are not, well, I was going to say not your fault, pregnancy, but now we actually do know what causes that. So kind of. Medications, psychological causes can cause constipation because this is the little brain, this is the big brain. As a matter of fact, my other partner yesterday, I said, I got to give my slides tomorrow. Can I show you my slides? And we were talking about poo. And she said, when her husband gets constipated, what she does is she stresses him out and it makes him poop. So every time he says, and I shouldn't tell you which partner because he didn't give me permission to talk about his bowel movements, but I'm going to tell him tonight that so she says, when he says, I'm kind of feeling constipated, she goes, okay, honey. She goes, listen, we have a lot to do today because you have to drop off the kids at a play date and then we've got to go shopping because we have to buy a gift for my mother and blah, blah, blah. And she'll give him this long order and he'll go, okay, I'll be right back. And he goes and he poops. Okay. And then, because they're connected. They're connected. And then pain. People don't want to poop when they're in pain for a lot of reasons. Okay. 3 main types of chronic constipation, right? So this is like if it's going on for a while. One of them is just like sort of slow transit, and some people just have slow transit. That's just the way they were built. The second is irritable bowel syndrome type C, because there's a couple of different types of irritable bowel syndrome. It's easy. Some you get more diarrhea, some you get more constipation, and some you get both. And then there's a condition called a category called disordered defecation, and that's trouble evacuating a stool even when they're soft, or you need to kind of dig out stool. These tend to be disorders of the very final end of your gut, like rectum and anal sphincter. And we're not really going to talk about these today because for the most part, people who have this know about it, and there tend to be like surgical problems like rectal prolapse or a stricture or things like that. So today we're really going to talk about just slow transit and irritable bowel type C mostly. And the difference between the two basically comes down to recurrent abdominal pain. So if you kind of have like constipation, but you don't get like spasmy pain after you poop or when you poop, you probably just have slow transit. Or when I say you, I don't mean you, but you, us, all of us. But if there's sort of recurrent abdominal pain associated with constipation, it's probably a form of irritable bowel. So that makes it easy. And then they usually report that their poops are in the 6 and 7 category. Whoops, sorry. Nope, that was 1 and 2 category. So that's rabbit poops, like little pellets, or a bunch of grapes, sort of lumpy and hard and stuck together. So a lot of chronic diseases are associated with constipation. So this would be part of a history. If you were the physician and you were interviewing somebody who says, oh, I'm always constipated, you would look at their chart, or if they were new to you, you'd say, okay, what kind of, chronic diseases do you have? And because this is America, diabetes, right? I was on a plane and there was oh, there's an emergency. Is there a doctor here? And I'm like, oh, but I'm like, okay, I have to do it because it's really stressful. But I go up and it's a little old lady. I'm like, okay, these are my people, right? And she passed out in the bathroom. And so I lay her down and they have an e-kit and I'm checking to see if, what's in the emergency kit. And I can take her blood pressure. But I'm thinking, ooh, she's really skinny and frail looking. I wonder if her blood sugar is really low. But there's no glucometer. There's no finger stick machine in the emergency kit on this airplane. And I'm like, oh my God, but what if her blood sugar's low? Maybe I should be giving her something, blah, blah, blah. And I'm like, ugh. And then I remembered, wait a minute, I'm an American. And I'm on an American plane. And I stood up on this 747 or something. And I said, excuse me, if you have diabetes, please raise your hand. 250 hands went up on this plane. And I said, great, keep your hand up if you have your glucometer with you. And still 100 hands were up. I'm like, oh, okay, keep your hand up if you've calibrated it in the last week and 50 hands were up. I'm like, keep your hand up if you've got extra lancets and test strips and there's 30 people. I'm like, okay, I'll take yours. Yeah, hey, it's good to be an American. Her blood sugar was fine. But anyway, it was oh, yeah, we're Americans. We get diabetes. Hypothyroidism, hyperparathyroidism, renal failure. This is very common, especially in Hawaii. Lead poisoning, we don't see so much anymore. Any kind of, this is neuropathy. Neuro, meaning nervous system. Pathy, meaning pathology, disease. Really generic term that I put up there. Why neuropathy? Little brain, big brain. It's a part of your nervous system. Parkinson's disease, multiple sclerosis, any kind of spinal cord injury. Why spinal cord injuries? It's part of your nervous system. Right? Any kind of autoimmune disease. Pregnancy, why is that under disease? Because it's a sexually transmitted disease. And cancers for different reasons, not even just colon cancer, all different kinds of cancers. Is this list comprehensive? Oh, no. Tons more. I think the big ones we see commonly, a lot in Hawaii, the Parkinson's, the renal failure, the diabetes. And medications. Is this list comprehensive? Oh, no. Anytime you put any pill in your mouth, the most common side effect, the most common is going to be something gastrointestinal. So if you're taking your medical boards and the question is, what side effect does this medication cause? Just pick something GI. You're going to be right. Boom, next question, right? So, yeah, some things cause nausea, vomiting. Some things cause, with iron supplements, some people get diarrhea, some people get constipated. And you'd be surprised. I see people all the time, they're like, I really don't take anything, just a multivitamin. I'm like, boom, cha-ching, multivitamin. Anything you put in your mouth. So, are going to be very, very common, a common culprit. Because we're Americans and we're all going to be on blood pressure medicine eventually. Hopefully not, but common things are common. Very common for blood pressure medications to cause constipation. So if you start a new medicine and you get constipated, that's likely to cause, and sometimes as people take medications and get used to them, their body kind of settles in, but sometimes they don't. Calcium channel blockers, beta blockers, So the calcium channel blockers are your like amlodipine, beta blockers are your like metoprolol, very common to cause constipation. Cold and flu preparations, that you do to yourself over the counter. By the way, no more. You're not allowed to do that over the counter anymore. Not okay. They cause too many side effects. Do something else. The saline nose spray, I don't know. We'll talk about it another time. You can't have it. Antidepressants, antispasmodics, like, always have, like, I was having spasms in my gut, in my bladder, in my back. All of those going to cause constipation. Antipsychotics, which sounds like we only use in people with significant mental illness like schizophrenia or things like that, but actually they're used a lot nowadays for all kinds of reasons. We use them a lot for behavioral issues with dementia, but people take them even for nausea because even though they're called antipsychotics, every category in medicine gets borrowed and used by every other category, right? Chemotherapy, anything that's against nausea, kind of that makes sense. Like you're targeting the gut. Urinary incontinence, like, oh, I'm not taking it for my colon. It's just because my bladder squeezes and I don't want to. Yeah, but the pill doesn't know that. It goes in, it goes everywhere. And then antacids, and then, of course, opiates. So if you get your knee replaced and they put you on oxycodone, you're going to have a heck of a time pooping. Let's try to avoid the opiates, and the only reason you should be using opiates chronically is if you've got like cancer-related pain. Like anything else, we got to clean up the store, okay? That was my 2-second public service announcement. Okay, lifestyle. So now we're getting down to like the heart of, I think, mini med school, right? Which is living healthy. Like I said, once more, if there was only one thing that you could take away from today, from me being here, move it, move it, move it, move it, right? So, like, exercise is going to be the key to pretty much everything. There's never going to be a pill that I could give you that's going to make you as well or treat, like, every symptom, every system in your body like exercise. And if you're not moving, it's going to be really hard to make you comfortable, like to just make you well, or even just feel good in your skin. So even if your ankle is broken, move your upper body. If your shoulder's hurting you, walk, do something, but keep moving. Because if you don't move, your bowels are not going to move, and nothing else is going to work either. Well, we do tell people drink more water. Like I said, my disclaimer, we're not really sure that there's an association, but we do sort of think that if we were able to do a study, it probably would help. Timed toileting. When are you making the private time for pooping, right? So in the hospital, we have a lot of trouble with this because patients need to get onto a commode or into the bathroom and they need help. So it's really hard to time it where there's the hot beverage first thing in the morning, and then a meal, and then getting onto the potty because we have to wait for the nurse aide, she's passing meds, whatever. But this is super important because your body responds to these signals with this big wave of contractions that we call peristalsis. So timing it. If you can get yourself on a beautiful schedule, probably why, like when you're traveling, you get constipated. And okay, avoid prolonged straining. Don't sit there and push and push and push. You're just going to give yourself hemorrhoids. It's not going to be helping. Body mechanics. See, does anybody know what she's using? What was this an advertisement for? Squatty potty, which one of my partners yesterday asked if we could put one in the office. I'm like, sure, why not? Squatty potty, getting like your knees up, like sitting forward a little bit, leaning forward, and getting your feet up off the ground. There's less constipation in other countries where, I'm sorry for people at home, but where people do America, we have raised toilets, and so we tend to then lose that body mechanics, extra help that you would get from squatting. Here's one that I started learning a lot about: regular sleep patterns. Regular sleep, and I don't know why this should have surprised me, because like I said, right, sleep is a brain issue, direct connection to the gut. And not only that, and I think maybe, I don't know if anybody else is going to talk about your microbiome, but does anybody know what your microbiome is? Anybody? Wait, say it loud.
Microbial population.
Right. You are not alone. We are not alone, and it takes a village, right? You, whoever you are, we could use me as an example, I am less actually me than I am the gajillions of bacteria, yeast, and other organisms that live on me and in me. And that relationship turns out to be one of the most important relationships of your life. Well, probably, and we call this whole population of bacteria, yeast, these other organisms that live on you, in you, with you, and who do a heck of a lot of the work of everyday life for you. That's your microbiome. And for anybody who's a germaphobe, I apologize, but these guys don't get rid of them. You can't get rid of them, first of all. You wouldn't survive without them. And the balance of which bacteria are living with you and which you don't have, oh my gosh, okay, is super important to your wellness. And you should say thank you to them. And actually, when you poop, you're pooping out. Your poop is mostly bacteria. They say to me, well, I'm not pooping a lot because I haven't had anything, I haven't been eating a lot. I'm like, it doesn't matter. Your poop is mostly bacteria. Anyway, how you move, wake throughout the day is super important to how you're going to poop. So you have a little bunch of nerve cells in your brain, the suprachiasmatic nucleus, and they respond to sunlight, and they respond to when you eat. And as long as you get yourself on a regular sleep cycle that's in line with this, you're going to do great. Who has trouble with this? People who are shift workers, like have to take the night shift or something like that, or people who are traveling. But your circadian clock, your day cycle, your diurnal rhythm affects every single part of your gut. So it's really important, if possible, to see if you can get a little bit of sunlight every day to reset that clock, be up in the morning, and get a good night's sleep. It affects not just the neurologic, the nervous system function of your gut, but even the balance of the bacteria in your gut. It's fascinating. Well, I think it's fascinating. Okay, you'll just have to trust me on that one. Diet. You guys are going to hear about diet later. I think one of the most, we talked about water and fiber. Fiber is super important. But fiber is not going to work right away, and we also have to make sure that you drink enough fluids if you're going to take fiber, otherwise you're going to feel kind of bloated. Big Kiwi has just came out with a paper about it's not just papayas that help you poop, or prunes or chia seeds. Kiwi was shown to be really effective, but we're lucky here in Hawaii, we get papayas and you can grow them in your backyard, right? And just because we're in Hawaii, avoid guava if you're constipated, because food is medicine and that's the opposite medicine. If we get to treatment and I'm going to talk about laxatives right now. The first category is usually the stuff people buy over the counter, like Metamucil and Benefiber. Once again, this acts like fiber, so it doesn't work right away. You have to take it with a lot of water. So is this good for inpatients or outpatients? Outpatients, because it's going to take a while and you have to drink a lot of water and whatever. Good for acute, like 1 day of constipation, or chronic constipation? Chronic constipation, right. And with these kind of things, you want to start low and build up and go slow, because otherwise you can kind of feel uncomfortable. And you can fart a lot, so just don't take it right before you're going on an airplane, because that's a sealed container. Yeah. Stool softeners. This is things like Colace and Surfac. Really, there's no good evidence that these work at all. And although they're commonly used, they probably don't cause any problems, but you're wasting your time. I put enemas on the same slide. Please, once again, we don't really want you using enemas chronically, only as needed. And then don't use, once you're older, I don't want anybody using like the fleets, because anything that you can absorb through your mouth, you can absorb through your rectum. It's the beautiful blood supply down there. And you don't need these extra electrolytes and things like that. Or people say, what about a soap suds? You don't need that. Enemas work by just sort of irrigation. They're just, and stimulating, that nervous stimulation of sticking something in your bum, and the lubrication of, like, you had to put a little, lubricant on it to put it up there. You don't need extra chemicals, and enemas should be a rarely thing, unless there's a serious medical condition, and then you'd already be talking to somebody about it. Stimulants. The stimulant laxatives are the Senna, the Bisacodyl, the Ducalax. Very, very popular. I gotta say I don't like them, because they're basically working to make that nervous system work. And if you're gonna be acutely, like one time, 1 day, 2 days, fine. But these, if you use them over and over and over again, you kind of wear out your gut. And chronically, people can get a condition called cathartic colon, which means they just don't respond to anything anymore. So this category, is it good for acute or chronic? Acute, thank you. Not for use chronically. Inpatient or outpatient? You're inpatient more. It's an acute situation. I'll use it for a few days. I just have to worry that a lot of times, people go home and they still think they're supposed to take it. No. Get your house in order. No. Osmotic agents. Not used as much, although they're gaining popularity. These are things like Miralax. You've seen that right over the counter. Lactulose, sorbitol, even artificial sweeteners. These work because they're big molecules that you can't digest, and they stay inside the tube of your gut. Oh my gosh, okay. And then, so your gut tries to even things out and puts more water into your bowel so that your stools are nice and moist and bulky, and then things pass out. They don't get absorbed, right? Because you can't make it into little molecules, so it's not going into your bloodstream. So, do I like these or not like these? Love these. This is my favorite. I think, would I use it inpatient or outpatient? Both, thank you. Would I use it for acute or chronic? Both, yeah. This is my favorite, very safe. Yeah, you can get a little gassy, but who isn't? This is why teenage girls have diarrhea. What do teenage girls do all day long? Right, they chew gum with artificial sweeteners, right? This is why sometimes patients with diabetes have diarrhea, because they want candy. You're not allowed to have candy with sugar, so it has that erythritol or sorbitol as the sweetener. This is also why people who drink milk get, especially older people, especially Hawaii, if you drink regular milk, you get what? Gassy, bloaty diarrhea. Why? Because the reason why we can't drink milk when we're older is because milk has a sugar in it called lactose, which is a glucose and a galactose that are linked, and we lose that enzyme that breaks it up and digests it. And so it's a big sugar molecule that can't be absorbed. What does that sound like? That's an osmotic agent. So, Like, worst comes to worst, you're constipated and you can't do anything else. You can drink a glass of milk, poop, right? Okay. This was just to show that the gut is really tightly linked to your nervous system. Highly innervated and very vascular, right? It's not just a blank tube. Like, a lot is going on, right? Things have to be absorbed, things have to be secreted. Every single neurotransmitter in your brain, the chemicals that send the messages to like tell you to like move or relax or whatever, every single one of those neuro, meaning nerve, transmitters, meaning message, right? The chemical messengers that keep you awake and make you, every single one of those from the brain is also in the gut. Okay, this is what happens. Your gut responds to distension. So you eat something, I don't know what that is. It looks like someone swallowed a whole lemon. Your gut normally will contract behind the lemon and relax in front of it. And this is regulated by different chemicals, neurotransmitters. I'm going to skip through this, except to say that many of these neurotransmitter receptors, this is the reason why medications will affect your gut, even if it's not designed for your gut, including dopamine. Remember we talked about Parkinson's disease? Parkinson's disease is an imbalance of dopamine, right? Even psychosis is an imbalance of dopamine. Dopamine very tightly linked to your gut as well as the little brain. And opioids, you have receptors throughout your body that are opiate receptors. And opiates are basically, all those receptors in your gut, it's like brakes, turning on the brakes, which is why acetylcholine, I only have like 2 minutes left, but I want to talk about acetylcholine because it's my favorite topic. Acetylcholine is a neurotransmitter that works throughout your body. Dr. Masaki and I deal a lot with acetylcholine because as our patients develop Alzheimer's disease, acetylcholine is felt to be the neurotransmitter that's greatly affected and decreases in the disease, Alzheimer's disease. So medications have been designed to increase levels of acetylcholine. Well, because acetylcholine is everywhere in the body and is so active, other drugs have been designed to decrease levels of acetylcholine for other illnesses. So there are some drugs that are pro-cholinergic, cholinergic, that's what that means, and they raise levels of acetylcholine in the body. And there's other drugs that are anti-cholinergic or lower levels of acetylcholine throughout the body. What happens is a lot of drugs that are given for other diseases like depression or urinary incontinence or vertigo are anti-cholinergic. And when you turn off acetylcholine in the brain, ACH here, do you see it? You're affecting acetylcholine in the gut. And that's why we try to avoid using anything that we can that's anti-cholinergic. Also because, remember what I said at the beginning in this paragraph, when we see levels of acetylcholine going down, we see people getting more confused, forgetful. Anyway, there are some laxatives that are designed to work on other receptors, like in the gut, and there are some special laxatives that are designed to counteract the effects of opiates on the gut. But remember what I said, really the only reason you should be chronically on opiates is because somebody has like cancer-related pain. Otherwise, not a good choice for pain management. If we can do, I think we should try to do something different. Anyway, remember the most important thing for benign constipation, annoying constipation, which is the vast majority of it, is patient comfort. This is the goal. You don't have to have 4 bowel movements a week. You just have to be functioning and happy. And this is what you look like when your goal is achieved. Okay, so I think now I'm going to take questions.
Thank you, Shari. Any questions already?
It seems like a cup of coffee in the morning is a good stimulant for a bowel movement. Is the caffeine what's doing it?
That is a brilliant question. Thank you. Oh, is that a microphone? I was like, what is that? Okay. I think that coffee probably works in multiple ways. I don't know if it's the caffeine, although that might have an effect, but any hot beverage, first of all, works because that liquid and that heat hits the stomach, and there's a reflex called the gastrocolic reflex, gastro, stomach, colic, colon, and when you eat something, it tends to, plus we tend to drink coffee in the morning when you're going to have that huge normal wave of peristalsis, and people who have their routine down, they have their cup of coffee, tend to have their, right? And there's probably other chemicals like theobromines and everything that are in coffee that also work. You can, if you're not a coffee drinker, you can probably get the same effect from tea or even hot water with lemon, although I think coffee is probably more effective, but it's such a complex beverage with so many chemicals in it, it's probably more than one. That's a great question. I do want to talk about, like, once again, the daily cycles. In a normal system, people tend to have 2 big waves of peristalsis a day, one in the morning and then a smaller one in the afternoon, and anything that you can do to augment that first wave, so warm beverage, privacy, good routine, good sleep, and responding to it are all going to help. So if we suppress that urge, we're on an airplane, we have no privacy, that wave of peristalsis tends to get lower and lower and lower. And it takes time and work to get it back up to where it is. So riding the wave is, to use a Hawaii.
I love that analogy. So if people take laxatives consistently for years, will that weaken the muscle so that they cannot push stools out and become more dependent on more laxatives?
That's a fantastic question. Like I said, there's different categories of laxatives. And for the most part, the ones I worry about are those stimulant laxatives. Because yes, those stimulant laxatives can have a side effect over years of interfering with the nervous system of the gut and its response. But other things like fiber or there's no evidence that it weakens your muscles. If it's something you need to do chronically, you need to do it chronically. There's another category I didn't talk about, like the saline laxatives. That's like the magnesium ones. Mag citrate, milk of magnesia. I also not in favor of older people using them. Your gastroenterologist may give you a one-time milk of magnesia or a mag citrate for your colonoscopy, but not a good chronic choice. And I would, if you can avoid the stimulant ones, the senna, the bisicodals, I would avoid those long-term.
Is it a good idea for older people to take a microbiotic tablet, say like Align?
Oh, that's a really good question that I'm going to leave to the dietitian. You have a microbiome, and it's already in you. I think if it works for you, that's fine. I don't think there's any real evidence that most of those things are going to hurt you. And you're getting it even if it's not advertised in most fermented foods. Yogurt, sauerkraut, I hate to say beer. Kimchi, thank you. Yes, thank you, sir. Kimchi. Fermented foods tend to have that. Kombucha, Kabocha? How do you spell? Yeah, I always mix up kombucha and kabocha. Yeah. Yeah, one is delicious and one tastes like a sneaker. Okay, yeah. So you do get, you know, bacteria and yeast and stuff in the foods that you eat. If one particular yogurt helps you more, good for you, I would say.
Can you talk a bit about small intestinal bacterial overgrowth, or SIBO syndrome?
Oh, wow. I'm not really prepared to talk about that today. That, that's a pretty important topic. I'm going to leave that for another day. Is that okay? Because
Absolutely.
that's, I don't feel like well read on that right
And
now.
that's a topic on its own, I think.
Yeah. I mean, we do see problems with it, and it's super, interesting and important, and because certain things get, different things that you eat get absorbed in different places throughout the pathway of your gut. Okay, that was a great question, but I'm not going to answer it.
Okay.
And you can't make me.
Anyone from the in-person audience? Any more? I have one more from the online. Are there any negatives to using the Toto washlet toilets? You know, the Japanese toilets.
Oh my God, I love that toilet. I do not know of any problems using like the Toto washer toilet or bidets. As a matter of fact, I think there's probably benefits. Because as Americans, we're one of the few societies that uses all that paper and like, which can cause irritation. And in a lot of other countries, they use a sprayer. You know, even in, like, I just came back from Bali, and like every bathroom has like a toilet and no toilet paper, and there's just a hose with a spray, and you just kind of spray and you wash. And many Asian countries that I've been to, and even some African countries, that's what they use. And if you go through the Narita airport in Japan, there's the Toto Museum. Has anybody ever been to this in the airport? Okay. How fun is that, right? It's this mini, it's obviously like marketing, but hey, I'm falling for it. It's this mini museum of all the latest Toto toilets, but you get to use them. Like, you get to shut the door and use them. And you open the door and the lid automatically goes up and the lights slowly come up. And it's just pretty cool. And they all have this bidet feature. And I actually think it's probably really good for you, and it makes a great present. I am not sponsored by Toto toilets. I have no affiliation with them. But I think they're probably pretty good. I think the scraping that we do with toilet paper is probably less healthy than a good irrigation with water.
I know all those noises scare me a little bit, but that's all I'm going to say.
Oh, yeah, in the Toto Museum, some of them, it's not just like water and how warm or how cool and the force of the spray and like direction of the spray. They even have like, you can make, like it has music or sounds and I think this is, silly, but important point. Little brain, big brain, and they're connected. If you don't have privacy, you're going to hold back. Most people will hold back. I think that might even be the reason why a lot of people, when they travel, it's not my toilet, and people are like, in the next room or whatever. And you're gonna miss that first wave of peristalsis, that morning wave, and the more you suppress it, the more it weakens. And you don't want to weaken that morning peristaltic wave. So the fact that it could make noise to cover the sound of plop, plop, like it kind of like, hey, you're laughing, but you all knew what I was talking about. That can help with the privacy and the relaxation. And also, your mind is very connected. So the sound of water, many of the Toto toilets make that water sound. So it helps people like to release and let go. We even use it in the hospital sometimes. I'll turn on the faucet for men who can't urinate, because everybody in the hospital has a little bit of trouble urinating, but men, because of prostates and which gets bigger as they age, and body mechanics, have a lot of trouble emptying their bladders, which can become quite a serious problem. So I go in, I'm like, are you able to pee? No. I turn on the water. Psh, and sometimes they can release. Okay.
Is constipation a cause of appendicitis?
Oh. I didn't read anything that said that. I have never heard of that. I think that, but just because I haven't heard of it doesn't mean it doesn't exist. That's one of my favorite things. Is like, if your doctor says, well, I never heard of that, your doctor is absolutely right. They've never heard of it. Doesn't mean it doesn't exist. I haven't read anything or found anything that links those two. But constipation can cause other problems besides the one I talked about. One of the patients that I actually became very close with over many years, I got consulted on when that patient was delirious, different patient than the first one, and so constipated that the hard stool in their colon was just pressing against their colon so hard and so dry that it gave them a pressure ulcer inside their colon, and those have a specific name, stercoral ulcers, and became quite a serious problem. So besides the problems that we talked about, like constipation can cause other serious problems.
Any other questions from our in-person audience? One last question. Does turmeric supplement help with constipation?
I don't know, but I think it's like the hot, it's like the hot, superfood now. So if anybody wants to, I bet Dr. Masaki would love, she's a great researcher. We should have her research that. I'm a Western medicine doctor. I mean, I'm an American, so I hear about stuff, but I'm not an alternative medicine specialist. I do believe that as Americans, we should link those two fields of study more closely. It's silly that they're separated, but I don't study turmeric, but I think it's worth trying.
Yeah, I've never heard of it. I do know there's a lot of turmeric in Indian food, but there's also a lot of chili pepper in Indian food. So,
right.
And then there's squatting toilets in India. I know constipation is much less prevalent there, but I'm not sure of a turmeric direct relationship.
Yeah, and maybe the next speaker who knows more about nutrition and foods, that would be a good rollover question. I certainly think we know that eating more real food versus American Western diets, like less chemicals, more food as opposed to, processed things, is going to help you poop.
Okay, thank you very much
Thank
to
you.
Shari. A very important topic. All of us who've ever had any issues with our bowels know this is a very important topic.